pulmonary hypertension and cardiovascular disease. So you're welcome on board, everyone. And this is going to be an 1 hour webinar. So when you have any questions, again, kindly put it in the chat box. And when it's time for questions, the Q&A session, we will answer all your questions. Thank you. So our first speaker is going to speak on pulmonary hypertension in Africa, evidence, diagnosis, and closing the gaps in the treatment access. I would like to welcome our speaker, who is in person, Dr. Anne Mocumbi. She is an associate professor of cardiology at the University in Mozambique, an affiliated professor at the Department of Global Health at the University of Washington. She is based in Mozambique, where she is the head of the non-communicable disease division. Okay, sorry. So we're going to, since Dr. Anne is not here, we're going to start the presentation with Dr. Bonaventure, who is our second speaker.
I am here, Dr. Marilyn.
Oh, that's wonderful. Sorry about that. Okay.
No problem.
Okay.
I was having problems with the internet, so I had to change.
Okay.
I was
It's a
sending
pleasure.
emails. Sorry about this.
All right. It's good to have you here, Prof. All right.
Thank you.
Okay. Thank you for alerting us. Okay, that's wonderful to know. As I said, her career focuses on poverty-related non-communicable diseases, particularly neglected cardiovascular diseases. Her research interest spans from clinical research to education and health management, with special focus on neglected communicable diseases, particularly cardiomyopathies and heart failure in children, as well as women's cardiovascular health and use of point of care technology to improvement of access to healthcare in low income settings. She is the co-chair of the task force for access to reproductive health services for women in cardiovascular disease of the Pan-African Society of Cardiology. She's again the co-chair of the working group of rheumatic heart disease prevention and control at the World Heart Federation. And she also co-chaired the Lancet Global Commission on non-communicable diseases and injuries of the poorest billion. So I would like us to welcome Prof here again while she dives into the diagnosis, evidence, and also closing the gap in the treatment access of pulmonary hypertension. Prof, you're welcome.
Thank you. Thank you very much. Apologies for the confusion in starting. And I would like to thank, let me try to put this back. So I would like to thank, in principle, the invitation that was done for me to contribute and participate in this conversation. It's a great pleasure to share. Let me see why I can't do this. Please bear with me. Can you see my screen now?
Yes, we can.
You can. So I just need to put this one. My mouse is a little bit.
We can only see you on the screen.
I think it will be enough. So I hope you can see now the presentation. So I was saying I would like to thank the invitation. It's always good to exchange with colleagues and hear different opinions on a subject. The subject I was asked to talk about is pulmonary hypertension in Africa, talking about the evidence, diagnosis, and how we are trying to close the gaps in treatment access. I would like to thank Dr. Marilyn for her kind introductions. And without further ado, I will start my presentation, which will have 3 times. I will want to talk first about the differences that we currently use in terms of definitions for pulmonary hypertension versus
Sorry,
pulmonary.
sorry, Prof, we
Sorry?
see your face, but we don't see your shared slides or screen.
Oh, sorry,
Yes,
sorry.
please. Thank you.
Why? You're using a system that is okay. Can you see now? I'm going
Yes, please.
to
Yes,
full
please.
screen
Yes, please.
and slideshow mode now.
Yes, please.
Oh, thank you so much. Yeah.
Okay.
So, secondly, we will be talking about pathways to infectious pulmonary vascular disease care, which is a specific complication in Africa. And finally, regional initiatives that can help us in surmounting this challenge of pulmonary hypertension. So I understood that I was talking to a community of health providers, but also different stakeholders. And because among stakeholders, sometimes we have patients who have more experience in terms of living with condition, I also expect, in a way, to kind of address their issues and their aspects of disease management, and to have their support in enriching the dialogue that we will have. So, what are currently considered forms of pulmonary hypertension? This slide, which it has very small letters I recognize, it's a slide that shows that the blue, the light blue, and the dark gray are respectively left heart disease, and lung disease are the major causes of pulmonary hypertension. If we look at pulmonary hypertension, has the thickening or stiffening of vessels of the pulmonary tree that don't allow blood to flow normally, and because of that represent a surcharge to the right ventricle. By definition, this can be any condition that causes this difficulty in flowing through the lungs. And because of that, in Africa, we have this spectrum. We have several conditions that are causing pulmonary hypertension, apart from the idiopathic forms of hypertension, which we call pulmonary arterial hypertension in general, idiopathic when we don't have a cause, and all the others, because for pulmonary arterial hypertension, where the restriction, the impediment to flow is on the arteries. So in these cases, you have resistance, a very high resistance to flow, which has its origins in the arteries. And because of that, this is a very specific group. It's a group that is not the biggest group. And in Africa, we consider the designation of pulmonary hypertension as most appropriate. Also because, as you will see in a minute, it's difficult to make the diagnosis of idiopathic hypertension, which is here marked in dark blue, when you don't have the conditions, a health system, and the access and the affordability to do a proper and very extensive diagnosis. So as I try to show here, you have schistosomiasis, you have congenital heart defects that a child can born with. You have portal hypertension, which may also be a cause of schistosomiasis, but it has other causes, which is a liver condition that restricts circulation through the liver, and because of that allows shunting of the blood without crossing the liver, going to the lung, and may also take other infections there. HIV, which is one important cause of arterial hypertension too, and finally connective tissue disease. So for you to say that someone has idiopathic hypertension, arterial hypertension, you need to have excluded all these conditions. And as you can see here in Africa, which is second to the right, we have less idiopathic diagnosis, but this may be because of the other conditions being less frequently diagnosed, but also because sometimes we don't have the capacity to fully exclude these conditions. So we assume sometimes that someone has schistosomiasis, for instance, without being 100% sure that this is the case. So the major challenges in access to care for pulmonary hypertension in Africa are first diagnostic gaps, as I just mentioned. If we look at the gold standard for diagnosis, which is right heart catheterization, it's usually an invasive procedure that can be done in specialized cardiac centers, and its availability is limited. Also, the cost and availability of these exams and the treatment itself are not for everyone in Africa, and the targeted pulmonary arterial hypertension therapies are remain very expensive and not always available. The infrastructure and the personnel is many times limited to referral urban centers, and this is another hurdle for patients that have this condition. And finally, socioeconomic factors also influence the timing for diagnosis, the timing for suspicion, and also the access to prevent quick progression of the condition. So again, these are the slides that I started with for definition purposes. If you look at these conditions, HIV, sickle cell disease, rheumatic heart disease, which is the disease of the valves in the heart, which is an infectious disease that then becomes chronic, lung disease such as tuberculosis, infections in childhood that leave a bad or less appropriate function. All of them are very common. Left heart disease is as common as in the rest of the world. So you have a recipe to have a lot of pulmonary hypertension, and pulmonary hypertension is in fact higher in every series that we study of heart failure in Africa compared to other parts of the world. So in Africa, heart failure has a specific group, which is this group of right heart failure, usually associated to pulmonary hypertension, and is also much more common in women compared to series in the rest of the world. So these characteristics are partially explained by barriers to care, as we mentioned, long distances between our homes and health facilities for diagnosis. In average, the diagnosis takes a lot of time, and it may represent going from one level of care to the other level of care, and also going to levels of care with different levels of resources, and many times without right heart catheter, which is the gold standard, as we said, to make the diagnosis. This can also be linked to low health literacy, like we said, which sometimes makes people have beliefs on different origins for conditions that they are affected with. The second aspect that I would like to ask, which is very peculiar to Africa, is that because of our high incidence of infectious diseases, many other conditions apart from schistosomiasis may also lead to pulmonary hypertension, depending on the age and in which we get the infection, and also require more than just the usual causes of hypertension to make the diagnosis. As I mentioned, schistosomiasis, for instance, is one cause. Tuberculosis or post-tuberculosis, we can also get lung dysfunction that leads to pulmonary hypertension, and several other diseases that are very specific to the vessels, like Takayasu, arthritis, and others. So the pathways to access for these type of conditions is difficult. HIV, up until some months ago, we had a very structured program. The incidence and prevalence of HIV-related pulmonary hypertension was decreasing very, very markedly, and this was a success of these programs. However, for schistosomiasis and tuberculosis, there is still a lot to be understood by researchers and clinicians. There is low access to specific testing for schistosomiasis, for instance, and there are no specific tests for post-tuberculosis disease. So it's not well known what exactly causes pulmonary hypertension, and because of that, we don't have specific targeting medicines for that. In rural settings, the problem is worse, and that's where poor outcomes are more accentuated. So schistosomiasis-associated pulmonary vascular disease is thought to be the first cause of infectious PVD, which means pulmonary vascular disease, to shorten pulmonary hypertension and to differentiate it for the idiopathic causes. It requires confirming chronic schistosoma infection, which is very difficult to do. You can do it via stools, via urine, or serology, but it never gives you 100% of specificity. You telling that definitely this is because of schistosomiasis. Why? Because it's widely present in many parts of the continent, and you can have some past schistosomiasis without necessarily this being the cause for you to have high pulmonary vessel pressure when you do the right heart catheter. Also, there are key steps that involve identifying hepatic disease, which in many times are difficult to follow. And finally, in many countries, because it's recognized as a very important cause of disease, schistosomiasis is prevented by mass treatment in schools. So it is a confounder to diagnosis that we have in our continent. This is not for you to read, but just to have a sense of how complex the infection itself is, the many phases that the parasite goes through when it reaches our blood vessels at entry points through the skin, in rivers or in other collections of water. And because part of the activities, daily activities for many communities are inside these waters that have these cercaria, which are then transmitted to our skin by snails, usually transported by snails, we have a very high prevalence of schistosomiasis in Africa. So the first problem is confirming pulmonary hypertension. Now you have a second problem when you have schistosomiasis, because both conditions are difficult to confirm. And not because we don't have the tools, but because in Africa, as we said, it's difficult to find the whole package in one health center or one hospital. And echocardiography, which is the best screening method, it being difficult to obtain in the rural settings, then all the chain for diagnosis is compromised. I will not go into details because we have a diverse audience, but I put here some criteria first for echocardiography, for ultrasound that we can use, which is a non-invasive exam. We can also use chest x-rays, chest CT scans, but all those are not easily available. For chest x-ray, the signs are only present when you have very advanced disease, so it's not a very interesting tool for screening. And microscopy of stools and urine, being standard, may be negative even when you have advanced disease. And the differential diagnosis with other conditions is also difficult because some of these conditions are present in many of our patients. Finally, and very important, even if when we have mass treatment, not every child that is treated has a completely cured from the infection, either because of reinfections, because we go back to our sites where we live and for the same practices and attitudes, so we are exposed again, either because it's proven that all the drugs are not 100% efficient. With this panorama of difficult diagnosis, low access to good quality diagnosis, low access to good therapy, there are some regional initiatives that I would like us to discuss, and I would like to share with you some of them. All of them in Africa are brought by usually professional associations, as you can see, the Pan-African Thoracic Society, the Pan-Africa Cardiac Society, Pulmonary Hypertension Association in South Africa, for instance. The other two initiatives are initiatives that are directed to Africa, but were born either by some countries in Africa, the PAPUCO that you see here, which is the Pan-African Pulmonary Hypertension Cohort, led by our colleague, Professor Zudi in Cameroon, and the Pulmonary Vascular Research Institute, which is a global institute, but has one regional group that is looking at African institutions to foster education and drug development. And I'm mentioning these initiatives so that people who are interested can join them. We need big numbers and all the countries to be involved to make better advocacy. Which strategies are being used for improvement? First, as we mentioned, decentralized care, because if we continue to have care centralized in big urban centers where there are specialists, we will not get most of the people who are in need. And secondly, using registries and education. One registry is the Papuco registry, that there has been a second registry in West Africa. Valve Afrique is one example, and there are registries that capture information. So this is one that also captured information on pulmonary hypertension. Although not specific, it also had information on pulmonary hypertension. What is the PEN Plus strategy I'm starting with? Now it aggregates 26 countries that are aiming to implement nationwide programs, but are still building their own models of care, where not just specialists do the treatment, but they are trying to push for a more decentralized diagnosis. And I'm talking about this initiative because it includes cardiac diseases, and because cardiac diseases are diagnosed late, many of them have already pulmonary hypertension as a complication. And for that reason, we have incorporated pulmonary hypertension as one of the markers and indicators for this program. It's a clinical program of care provision in rural settings mainly, and it's focused on district hospitals. In district hospitals, why are we including? Because if we continue only diagnosing at the top of the health systems, of course, we will not reach many people. And this is an example of a colleague of mine that published, Dr. Sabino, from Mozambique, where you have the diagnosis mainly at the central hospital that is far away from the rural areas where you can have patients in need in rural districts. From these rural districts, it's very difficult for people to reach the village where the hospital is. It's very difficult for them to be referred for any of these exams we are talking about to a higher level, the provincial hospital or the provincial level, which may be 300 kilometers away from the rural district. And furthermore, to the central hospitals where the real care is available, which are the capitals or the regional capitals, it's even far. So this is an example of more than 1,000 kilometers a child would have to run, or an adult would have to go to get a diagnosis. Even talking about screening, initial diagnosis and confirmation, you can see on the right side the techniques that we can use. And you see that it's impossible to follow this if you have lack of availability of this diagnosis at the district level, at the provincial level, and at the central level.
Prof, please, you have 1 minute remaining. Thank you.
Sorry?
You have a minute remaining.
Oh, I will have to go faster, yes. So this initiative is now in 26 countries, as I said, in different phases of implementation. And task shifting, meaning specialists teaching non-specialists, is the primary attitude we are taking. Because I don't have time, I will be very quick. These technical challenges are being addressed. We are transferring to non-specialists capacity to do echo, capacity to follow algorithms that can teach and identify quicker, and capacity to use algorithms for easiness of diagnosis, using X-ray for suspicion, which is a late stage, but helps referral when you have people outside, and also non-specialists using echo, because echo is something that can be taught to people who are not specialists and help us in finding more and more people in earlier stages. So my last slide is just to summarize and thank for your attention, and also for our sponsors who are helping in these studies and care. Thank you so much. I'm stop sharing.
Thank you so much. Thank you so much, Prof. Thank you. So please, if you have questions, you can put it in the chat box. It will be addressed as soon as Dr. Bonaventure finishes. So please, thank you so much for such an insightful presentation. Our second speaker is Dr. Bonaventure Dzekem. He is a physician, an entrepreneur, and a public health policy specialist with a deep commitment to advancing global health ethics and leveraging technology for impactful health solutions. Dr. Bonaventure earned his Doctor of Medicine from the University of Wien in Cameroon, during which he completed a thesis in pulmonary hypertension in sub-Saharan Africa. He holds a master's in public health policy from Harris School of Public Policy at the University of Chicago, USA. With a career rooted in clinical medicine and global health, Dr. Bonaventure brings a uniquely multidisciplinary perspective to the challenge of pulmonary hypertension in Africa. He began his career as a practicing physician in Cameroon, an experience that directly shaped his understanding of the systematic barriers to early diagnosis of conditions such as pulmonary hypertension in resource-limited settings. He His multifaceted expertise includes several leadership roles. He has served as a program manager at the University of Chicago Center for Global Health, as a consultant for the Task Force on Patients' Perspective for the World Symposium on Pulmonary Hypertension, and currently serves a 2-year term as the trainee advisory committee for the Consortium of Universities for Global Health. In 2018, he was named an honorary Obama Scholar, and these roles have allowed him to expand his impact not only on patient care, but also policy and research. He completed his internal medicine residency at the University of Chicago and is currently a cardiology fellow at Brigham Women's Hospital, Harvard Medical School. I would like us to welcome our second speaker, who will be speaking on the burdens and drivers of pulmonary hypertension in Africa, a key contributing factor and improving early diagnosis. Dr. Bonaventure, your audience. You have 15 minutes. Thank you.
Thank you very much for that kind introduction. Can you all see my screen?
Yes, please.
Perfect. I'm Bona, as she rightly said, and I'm really happy to be here today to talk about a condition that is very dear to heart. I started my clinical career and research career in pulmonary hypertension, and I'm very honored to be sharing this virtual stage actually with Dr. Mocumbi, whom I got to know through Dr. Zudzie in my involvement in the Pan-African Pulmonary Hypertension Cohort Study, and during which we went ahead to co-publish several articles on PH in the African continent. And so today I'll be talking about the burden and drivers of pulmonary hypertension in Africa, focusing a little bit more on key contributing factors and how we can improve early diagnosis and outcomes. And I'll share some data that Dr. Mocumbi already shared, but looking at it from a different perspective. We know that a couple of days ago, the World Pulmonary Hypertension Day was celebrated under the theme Hope in Every Trial. And I think this is very important and very timely, because as you would see later in this presentation, Africa continues to be underrepresented in several clinical trials, not just on cardiovascular diseases, but generally. And so we know that 75 million people are affected by pulmonary hypertension worldwide, but a striking number is that 80% of these people live in low and middle income countries. And you can look at the heat map, you see that Africa is very, very much well represented. And the other thing is that conventional therapies for systemic hypertension do not necessarily work for pulmonary vascular diseases and right heart failure, which is a consequence of pulmonary hypertension. We talked a little bit about the group distribution of pH. We know that in Africa, this differs a little bit from the West, which that generates a lot of data on this condition, predominated by group 2, but the driver is mostly rheumatic heart diseases and poorly controlled high blood pressure. We also know that patients tend to present at a very younger age in the African continent, with most median age of diagnosis somewhere around 40 to 50, as compared to more than 65 in the Western world. And late presentation at time of diagnosis is also a common feature in PH in Africa, with most people presenting at functional class 3 or 4. There is also a strikingly very high mortality and in-hospital mortality in some studies, including the one that I did at the Shison Cardiac Center, was as high as 30%. And the other data point is that the diagnosis delay is about 2 to 4 years from the time of first symptom onset. And these are key features that distinguishes pulmonary hypertension in Africa from that in the Western world. But I'll spend some time talking about the key drivers of pulmonary hypertension in Africa. We know that Africa's pH is shaped mostly by infectious diseases that remain an endemic across the continent. And we heard a lot about HIV, schistosomiasis, and TB already from Dr. Mocumbi's talk. But we know that over 25 million people in Africa live with HIV. with 0.5% of them going forward to develop pulmonary arterial hypertension. And 0.5 might look small, but if you take 0.5% of 25 million, this is a significant number of people. And then 200 million people globally are living with schistosomiasis, as we already heard. And this is a leading cause of group 1 pulmonary hypertension. And if you know anything about parasitic diseases, you know that they are very much endemic in low and middle income countries, with sub-Saharan Africa not excluded. Tuberculosis and post-tuberculosis changes are also very highly implicated, with post-TB lung changes restrictive and obstructive, leading to group 3 pulmonary hypertension. The other key driver of group 2 in Africa is rheumatic heart diseases, which is a sequela of streptococcal throat infection, typically in childhood. And even with the advent of antibiotics, we still have this as a very common condition in the continent. And then there is newer research that is showing that human herpes virus type 8 and other viral exposures lead to immune activation and pulmonary vascular remodeling, leading to pulmonary hypertension. But as Africa continues to undergo its epidemiological transition, we now also know that not only infectious diseases, but non-communicable diseases are also layering into an already heavy infectious disease burden. And we can see that, uncontrolled hypertension, which invariably leads to left ventricular dysfunction, contributes significantly, more than 60% to left heart, to group 2 pulmonary hypertension in Africa. And then chronic lung diseases. And I would highlight that, of course, there is smoking, but we also know that in the African continent and most low and middle income countries, we mostly cook indoors with wood, with coal and biomass fuel, and this leads to significant indoor air pollution and invariably chronic lung changes. In one of the studies that we published, sickle cell is very linked to a high mortality, and this is probably because of the sickling in the pulmonary vasculature that leads to obstruction. But we also know that sickling in the vasculature also leads to vascular remodeling that leads to pulmonary hypertension. On the realm of drugs, toxins, and herbal medications, I'll focus a little bit on herbal medications, because we know that there continues to be a high use of unregulated traditional preparations in the continent. And some of these concoctions, we do not know their effects on the system. And so it continues to be a problem, leading to some of these conditions that we now know as pulmonary hypertension. Peripartum cardiomyopathy, as we know, is very common in African American and Black population, but it's more even specifically in the African population. It goes underdiagnosed and usually is very fatal, that leads to pulmonary hypertension, and of course connective tissue diseases that go underdiagnosed in the continent as well. And there continues to be a systemic barrier to diagnostics of this condition in Africa. An estimated 8 out of 10 patients with pulmonary hypertension still go undiagnosed in the continent. And why is this the case? We know that the symptoms of pulmonary hypertension are very non-specific. Most patients come in with dyspnea, which is shortness of breath. Most patients come in with fatigue. And these symptoms commonly overlap with conditions that are more common, like anemia, malaria, and even HIV. And so most providers that see patients with this condition tend to misdiagnose it as such. We also know from the previous talk that there is low clinical awareness of this condition. And so most people do not tend to look at it that way. And of course, limited access to echocardiography and right heart catheterization, which is the gold standard for diagnosis, is almost completely absent in the continent. So you can imagine, from a large pool of patients with symptoms and signs that could be suggestive of pulmonary hypertension, very few of them end up being diagnosed. But what can we do to improve this? There's, of course, several ways. Public health awareness and advocacy is one of the strategies. We need to continue to do task shifting and training our primary care providers to use ultrasound and be able to diagnose this condition. But we have to also start developing context-specific guidelines for Africa. And in this study that Dr. Zudzie, myself, and Dr. Mocumbi published in Cardiovascular Diagnostics and Therapies in 2020, we outline and propose a diagnostic algorithm for pulmonary hypertension in Africa, and starting with clinical suspicion, using more available tools such as the chest X-ray with some signs that could be suggestive, or the EKG, looking at right axis deviation, right atrial enlargement, or some of the signs that could suggest that one could be having or developing pulmonary hypertension. And of course, in centers where you have right heart catheterization, you can go ahead and do it, but we know this is very limited. And so we focus more on echocardiography strategy for the diagnosis of pulmonary hypertension with a right ventricular systolic pressure of more than 35 being highly suggestive. And there are also other echocardiographic findings such as right atrial enlargement, right ventricular dilatation, that could be very suggestive of pulmonary hypertension. And then after that, you would use your sort of clinical history, physical exam findings, and imaging data to group the patient based on WHO groups. The treatment options are also very limited. We know that pH-specific therapies like endothelin receptor antagonists, phosphodiesterase inhibitors, and prostacyclins are largely unavailable. The generic sildenafil that can be used for this is sometimes available, but still we tend to pay out of pocket, and we know that in the African continent, insurance schemes are very limited. And then we do not have pH-trained specialists in the continent, so we have very limited workforce for to look for this condition. And I can count on my fingers a few people that I know that are specific, Dr. Mocumbi being one of them, Dr. Suzie, and a few colleagues from South Africa. And so we still have a limited human resource capacity to tackle this condition. This leads me to what I call the double trial of pulmonary hypertension in Africa, which is the patient's trial and the clinical trial. The patient's trial, I look at it as the physical hardship of navigating the under-resourced health system, which leads to misdiagnosis, late-stage right heart failure, and lack of affordable disease-specific therapies. And so most of the patients go suffering this condition for too long. And then the clinical trial is referring to the systemic failure of the global and scientific community to include African populations in randomized controlled trials that dictate modern care. And what is the result of this? There is lack of evidence-based medicines that lacks external validity for the African patient. And to confront the first, we must first of all tackle the second. Just last month, Dr. Guy and his colleagues published in the Journal of the American College of Cardiology this systematic review of randomized controlled trials. And you can see that Africa has 19% of the global population and over 25% of global burden of disease. But if we look at the evidence that Africa generates, it is very, very limited. Only less than 2% of the global phase 2 and to 4 trials are hosted in the African continent. And in this study, this systematic review that I talked about, in leading cardiovascular journals between the years 2019 to 2024, only 0.6% of randomized trials were conducted in the continent of Africa. Those were 2 studies, actually, just 2. And only 2.7% of multi-continental trials included Africa. Those were 9 studies. And so we can see that Africa generates very little data when it comes to cardiovascular conditions, and pulmonary hypertension is not excluded. And so we cannot successfully treat an African epidemic relying solely on Western clinical evidence. We need to start generating our own data. And so how do we improve this going forward? Dr. Mocumbi talked about some of these things, but I look at it from 3-pillar perspective. First is the policy perspective, where I think we need to continue to encourage including pulmonary hypertension in national guidelines. We've seen some successes from hypertension and diabetes, and we can do the same for pulmonary hypertension. We need to continue to try to include the specific therapies that I mentioned before in the medicine list and in the insurance schemes, ensuring that they could be covered. From a capacity and care perspective, I think it's time for us to start thinking about building regional PH centers with availability of right heart catheterization, especially at the tertiary level, so that as we decentralize care, and do task shifting to the primary care level, we can also ensure that even with echocardiographic screening, when there is high suspicion, patients can ultimately, if possible, get right heart catheterization for diagnosis. And from a research perspective, we have to continue to increase and include Africa in pivotal PH trials. This is very critical. But not only relying on Western-generated clinical trials, I think it's, like I said, it's also time to start generating our own data by creating African PH registries. We talked about the PAPUCO registry already, and start leading our own research. Specifically, if you think about Western research, they are not going to focus on pulmonary hypertension, looking at it from an HIV, schistosomiasis, rheumatic heart disease perspective, because that is not the prevalent etiology in the Western world. And so we need to start generating this data, looking at it from our perspective. And my closing thoughts, we know that the burden of pulmonary hypertension is real, it is measurable, it is addressable, and it is ours to act on. We also know that the drivers are well known. There's infectious diseases, there is inherited conditions, there is non-communicable diseases, and the environmental factors. So we know where to look exactly. But the path forward is also very clear. We need to increase awareness. We need to improve access to care. We need to build our capacity and ensure that Africa is included in global science. And with that, I'll end back to the theme of this year's World Pulmonary Hypertension Day, and say that hope, there is hope in every patient who is living with this breathless condition and awaiting diagnosis. But most importantly, there is hope in every clinical trial that finally includes Africa in it. Thank you very much, and I think we can take questions.
Thank you so much. Thank you so much. We're very grateful for your time. Thank you, Professor Anne, and also Dr. Bonaventure. So please, if you have questions, I've seen that Prof has answered 2 questions already in the chat box, but I'll still read it so that those who still want to ask further questions would go ahead. So we know that there is hope. There is hope in every trial. And if we know that there is hope in every trial, it's very important that we still have hope in Africa that we will make it. And it's possible. It's not impossible. And definitely there will be a solution to all these struggles. Yes. So the first question is, in what way can you say that genetics play in pulmonary hypertension compared to some other conditions in asthma and in pulmonary hypertension, considering the heritable condition? So I know, Prof, you answered it. Would you like to answer it again so that the other audience would also get it? Then I move to the...
I will give time to other questions from my friend, Dr. Dzekem, unless someone wants an extra explanation. Like any other condition, there are situations where genetics play a role.
Yeah. Okay. Okay, I've seen that you answered them. So there is a panel discussion question here. So this year is actually the World Pulmonary Hypertension Day, and the theme is hope in every trial. I would like to also acknowledge the founder of the Cardiac Community Initiative, which is Oyetunde. So I know she's online and she's hearing this. So Oyetunde, thank you for making this happen. So if you have questions, you can put it in the chat box. So a powerful reminder for this CS theme, which is hope in every trial, that clinical research is central to improving the outcomes to every pulmonary hypertension patient. Yet Africa has historically been absent from, and I think Doc mentioned that, from majority of these clinical trials, meaning the drug approved globally may not fully reflect how the disease presents or progresses in our population. How can Africa patients or clinicians and patient organizations work together to increase participation in these pulmonary clinical trials? and what needs to be changed in policy. I think that was also mentioned, policy, infrastructure, and also awareness levels to make this a reality. Dr. Bonaventure, would you like to take it? But I think you mentioned it.
I can touch on that, and I think I kind of alluded to that as well. I think it is very important. We know from especially that a lot of funding in research generally globally comes from high-income countries, and we know that things can always change. If you know, most recently in the current U.S. administration, a lot of funding in global health was cut, more specifically funding on HIV. And so if we continue to rely on outside sources of funding, then we can be run into issues like that if this is our reliance. So I think there is an opportunity for us Africans and the African community to reflect on itself, and African clinicians to reflect on themselves, to think about generating our own data. I think if we start thinking about not only being participants to these trials, not only being, a US study is generated and Africa serves as a site, but also thinking of initiating our own studies, I think that goes a long way to generate our own data that we can use to act on and that we can use to understand. Because even when a trial is designed outside of Africa and includes Africa, most trials are designed with the thought of the population in which that trial was designed. And so the outcomes are not necessarily focused on the African continent. But if we design an African trial, we can focus the outcome specifically on Africa. And from what we can do from a policy perspective, I think we've seen successes in several infectious disease conditions. And with the epidemiological transition, we can start using what we know, our learned experiences, and applying them to conditions that are devastating, yet considered rare as pulmonary hypertension, no longer rare. For example, there is a lot of success we've seen from campaigns in malaria, HIV, and we can start shifting those learned experiences to conditions, non-communicable conditions such as pulmonary hypertension. I think we can use those learned experiences to apply to these conditions as well.
Thank you so much.
I would like to add on top of what was said by my co-speaker. I think that also there is a question on what the young clinicians can do. Dr. Bonaventure already said many of the things. I think that the young generation just needs to be brave and bold and do not fear coming up with ideas, like he said, of getting data, no matter how we think that it's not enough, it's not a very big cohort. If each of us does, we are 50 people here, each of us has 5 patients, we have already a very big cohort for pulmonary hypertension. And I think that maybe for the cardiac community, leaders and the organizers, I think that we can help you organizing the youngsters that are here, the young generation of doctors, to really go ahead and be ready. To be able to do these clinical trials, we also need to be ready. And being ready is pushing at least to have suspected patients that can then be taken through a path that leads to diagnosis and allows us to get into these registries. This registry, Papuku, was done by people without any money, any funding. So, Dr. Bonaventure, I'm grateful for you mentioning this. And I think that we just need to excite our younger colleagues and really support them. Thank you.
Thank you both. Thank you both so much. I think the questions in the chat box has been answered one way or the other through your, contributions. I would like to ask, how does AI currently play a role in early diagnosis of patient with pulmonary hypertension? Because we have most patients diagnosed, late, And most patients with heart failure, looking at the mimic, there's always a mimic of how, pulmonary hypertension symptoms are, and also heart failure patients. And secondly, also with patient with HIV, do we think patient with HIV, they should all be, screened? If there is access, depending on if the person is in a tertiary, should it be part of their screening to just detect whether there is any symptom of any pulmonary hypertension? Thank you. Oh, any of you can answer. Prof, would you like to go first, or
I will let Dr. Bonaventure as an expert to end. I will start.
Okay.
You have to get started about that.
I will humbly start. I think that, sorry, go ahead.
Oh,
no,
Prof,
I
you
want
want to
to leave you for the end. So I will just say that I believe fully on AI. We need to have this courage of having patients, put them into the data sets that are able to be transformed on AI, because we need an African AI set. The problem of relying on what others have done is that we are not like them in many aspects, and for anatomy, for physiology, variants of normal, we really need to have our population. So again, the fact that we can work together and build a community together can help us also in using AI to support diagnosis for people who are not specialists, looking at algorithms on iPhones, etc. Dr. Bonaventure, please.
Thank you.
Yeah, Prof, I think you articulated that very well. I totally agree. In the world we live in today, there has always been talk about AI is going to take our jobs, but I think the counter argument is that AI is going to take the jobs of people who are not using AI. And so I think in resource limited settings like ours, you can imagine the impact and how AI can go a long way to sort of improve our care. And if we're thinking about decentralizing care, applying some AI tools, there are free resources online that we can use. For example, if we have health centers that do not necessarily have a cardiologist, but are able to afford a point of care ultrasound or an EKG machine, these are tests that if obtained, can use some AI tools to analyze them. And so I think that is where we can use AI, not necessarily on site, but remotely, to help us to analyze some of the data to diagnose and hopefully treat this condition. And lastly, on HIV, screening patients with HIV, I think we know that HIV is a predisposing condition for many cardiovascular conditions, including pulmonary hypertension. But of course, when we always talk about screening, we cannot say screen everybody, because screening has to be cost effective, right? It comes back to us having a high index of suspicion in a patient who is presenting with symptoms and signs that could be suggestive. So I think it still goes back to that. We should be screening patients with HIV who have symptoms and signs that are suggestive. If you have a patient who is a survivor from TB and has some chronic changes, those are patients who might be at risk for developing pulmonary hypertension. If you have a patient with HIV who has an increased risk of developing parasitic infections like schistosomiasis, they should be screened for that. And so that is, I think we should sort of tailor care and personalize care, not necessarily saying we should do massive screening, because that would not be cost effective, especially in our resource limited settings.
Thank you so much. Thank you so much. And thank you to all our participants. If you have any questions, please, we have a few minutes to end. You can put your question in the chat box, or you can raise your hands for your questions to be answered. Thank you for staying on for an hour and 2 minutes. And there is a survey in the chat box. Please take time and fill the survey. And if you want more of this is Cardiac Community Initiative. It is a non-profit organization in Nigeria who supports patients who have been diagnosed of pulmonary hypertension. They engage in so many activities with cardiovascular diseases, championing pulmonary hypertension, which is led by Ayotunde. So please, if you're in Nigeria, you could join in advocacy as a young clinician. So please, we're still open up for questions. Any last words from you?
I have a question. Okay.
All right,
my
go
name
ahead.
is Tunde. I am the founder of Cardiac Community. I live with pulmonary hypertension, and it's so sad to say that with the how serious pulmonary hypertension is, with the amount of associated disease, there's still very, very little awareness, and it's still in Africa. So I just wanted to ask that, is there a reason why people don't take pulmonary hypertension seriously, or what can we do to like get them to take it more seriously, get it to be more priority? Thank you.
I had my hand raised, but thank you. Thank you very much. I think that first I would like to congratulate Ayatunde. It's very important to have this kind of initiatives. It's very good to engage researchers and the communities of patients to discuss things together. Patients know a lot of what we don't know. Myself and Dr. Bonaventure, we don't have pulmonary hypertension. We can't talk about pulmonary hypertension from a perspective of a patient. And I think that this is very important. I would like to mention that we have a colleague here who is the lead of communication in the African Co-Secretariat for the NCDI Poverty, Eva Nilsson, who is here. I think that it would be nice for us to put and continue this contact with him. We need to create a community of people who have interest, and this community involves patients. So please reach out to Eva Nilsson. He is the lead of engagement in our community of the NCDI poverty, and we have interest in having patients as part of this community. Because many patients don't come, Ayatunde, because you don't start the disease the same way. Some people may have symptoms, but as Dr. Bonaventure said, many of them in the earlier phases where you have the best chances of improving your quality of life and live without many complications, they don't reach hospital. And sometimes when they reach, we health professionals are also not trained to quickly identify and to be able to train this patient, educate them, and guide them on how to get a full diagnosis, how to manage the risks if they have risks, not to make the disease worsen. And we are not able to treat, because what is a big injustice is not to have equality in treatment, equality in opportunities for diagnosis for people who are born in a place that is less developed and has a weaker health system. Over to you, Dr. Dzekem.
Prof, I don't think I have much to add. You articulated that very well. I think, and I echo you to say, I think these kind of initiatives are very, very important to continue to raise awareness, because, we might know it in the medical community, but patients also need to, the general public also need to be informed about this condition. The other thing that I would add is that I think there's been a lot of focus in Africa for so many years on infectious diseases, right? And so we know a lot about malaria, we know a lot about HIV, we know a lot about TB. And so it's time to start knowing a little bit more about some of these non-communicable conditions.
Thank you so much. Thank you. Thank you for your brilliant answers. So there is a question in the chat box concerning the breakthrough with high efficacy in treatment of pulmonary hypertension. Has there been any data of the use in Africa, and how can Africans assess treatment?
Yeah. Thank you for the question, a very important one. I think that, again, it's an issue of equity. It's an issue of those that are left behind being usually the ones that are not at the top of the research, the clinical care, education, etc., on a given subject. Because we don't have access to these drugs at the first use, like we saw for COVID, for instance, with the vaccines, because we don't have our own production of these drugs, because we cannot afford the prices, we are also left behind for research. You don't consider that researching and using your community to do community is ethical. So the answer is no, we don't have access to certain step, but we don't have access for reasons that are disparities in the world. No African is doing it, maybe people who have, but it's very difficult because even to do drugs that are very good, they are good as the system that is providing them is elevated to the level of the drug. So you need to have good follow-up, you need to have other conditions surrounding yourself, your way of living, that go along the drug that you are doing. So this is something that you have to continue to fight. We all have to continue to fight because access means everything. And also going after the social determinants that make you not a good fit to use a good drug. Thank you.
Question about sotatercept. As we know, it's a newer drug that is still mostly in phase 3, I believe, maybe getting to phase 4 trials. So it's even in the Western world still not very available. But I put in the chat, the cost is astronomical. The treatment per year for sotatercept is $240,000. And so this is even for patients we see here in the United States is still probably cost prohibitive, not to talk of Africa, but it's a drug that is studied mostly here. We've not studied in Africa. It's still in the trials, but it's an important question. I think maybe we can think about getting the more well-established medications like prostacyclins that could be more affordable. And then hopefully at some point we can get sotatercept. But we have a long way to go, but not impossible.
And also to take measures to avoid people having pulmonary hypertension, because many conditions, as we tried to showcase here, are treatable. And if these conditions are treatable, they prevent pulmonary hypertension. For those who are genetically determined, but for all the other ones, you need HIV, you need to prevent getting exposed to schistosomiasis, and then you will prevent pulmonary. And to have a quick progress to a very malignant disease, and this is where we also need to invest. But we will not reach these drugs, all of them, before we have enough use of the drug, and that's usually when a new drug is coming, because the market is like this. Yeah.
Thank you very much. All too soon is coming to an end. If anybody has any last questions, but I would like our presenters, our speakers, to give us their last words, especially if there is anyone who knows any patient or has nursed any patient. What are some of the most, what is one or two things that we could, tell our patients to support or encourage them, especially knowing that there is no, cure to this disease? Thank you.
Yeah, thank you. So I would say that patients need to be empowered. We need to have these conversations and improve our language when we are speaking with patients. We health providers and we researchers. And we need to create communities of patients. I'm happy that the cardiac community is also tackling pulmonary hypertension. Patients with pulmonary hypertension should make groups and promote peer support, promote peer empowerment. They have to understand the disease and to help each other. These type of communities are a very big support to advocacy, because then a lot more people are involved in fighting for the same thing. And I think that also it reduces the stigma in our communities, because sometimes we have no knowledge, but sometimes we think that this is caused by something else, and this is many times a stigma. In African communities, we know the belief in the extra ordinary, in things that are not scientifically proven. It's part of our culture, so we cannot fight it, but we can together change and educate more and more people, empower the group of patients that are living together and battling together to find ways or easier ways to live with their condition. Thank you.
Thank you so much. Thank you so much, Prof. Anne. And Dr. Bonaventure, any last words?
No, I think I would say kudos to the cardiac community. I think for every patient who has pulmonary hypertension or who thinks that they have pulmonary hypertension, these are groups to reach out to. Be empowered to reach out. Be empowered to go to your primary care provider and ask, what about pulmonary hypertension? Do you think I might have it? Because I think even we as health providers may not think that way. And so we need to continue having conversations such as this to continue to raise our awareness, and have groups such as this. People should feel free to reach out to these communities that can have resources, but also to registries, to people like Dr. Mocumbi, who are leaders in the field in the continent. That would be, my last words.
Thank you so much. Thank you so much, Prof. Mocumbi. Thank you so much, Dr. Bonaventure. And thank you to all our audience, clinicians. Let's go keep empowering people and keep supporting them. And I'm sure very soon we'll have clinical trials here in Africa too. So thank you all for joining us. And this is Cardiac Community Initiative by Oyetunde. So you could please join using the link. You could see them on the social media platforms and also the website. Thank you for joining.
Thank you very much. Thank you all.
Thank you.
Thank you all. Thank you very much.